Hello, everyone. Happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note, everyone. Am I audible and visible, everyone? Okay. I thank you so much for that, guys. So, welcome to this session, which is all PYQ based. Because remember, for every exam, it's very important, that you master the PYQs because it gives you insights into what kind of questions are asked. And you cannot afford to make a mistake in a PYQ for sure, because that is something that will be done right by almost all the students, right? So you cannot make a mistake in PYQs. So first, let me tell you the trends and insights into, what kind of questions have been asked in radiology exam recently, and what do you expect for the upcoming exam. So the trend that we are seeing, emergency radiology images are definitely asked in the exam, like be it pneumothorax, pneumoperitoneum, or the various CNS hemorrhages like EDH, SDH, SAH. One of these is there in almost every exam. Then in the recent years, there have also been questions on radio anatomy, like, identifying the liver segment on CT, the rib identification, anterior, posterior, what number rib is it, basal ganglia identification on MRI. All of this is important. In the recent year, there's also been a question on barium swallow identifying pyriform sinus. Right, so one step ahead questions are being asked in radiology. There are questions on investigation of choice as well. The favorite like being the ureteric calculi, NCCT. Okay, and what is most expected for your upcoming exam, looking at the trend and the way the questions are changing, that radiology will be like a part of integrated clinical question. So along with the image, your clinical history also helps you to come to the answer, right? That's very, very important, and that is why learning in an integrated manner is absolutely important. Now, since you have video based questions as well, right, that were asked in the recent FMG exam, and they would be asked in the upcoming NEET PG exam as well, that's what everybody is speculating. So you might have one question in radiology which is video based, though you have many other subjects and many other topics where video based questions, of course, are more likely. But in radiology, it can be like an ultrasound clip which can be there, or an angiography clip which can be there as a video based question, right? Okay. I think we have discussed this. The anatomy wala part in LRR. Also, we have upcoming. We'll discuss there as well, and contrast where to use what. Okay, we'll do that as we discuss that topic. So let's start discussing the PYQs quickly without any further delay. So guys, this was the question asked in the recent FMG exam. This is from FMG June 26 exam that we had. So tell me, what is going to be the answer to this question? What is diagnostic of PCOS, PCOM, the polycystic ovaries in adults? Because remember that in adolescents, it is recommended like not to do ultrasound because, in adolescent having a lot of follicles is common. So ultrasound is not recommended there. Absolutely right, with the high resolution ultrasound coming into play. Previously, it was said that more than 12 follicles, but now it is more than 20 follicles in at least one ovary. It's not compulsory to have in both the ovaries, and the ovarian volume should be more than 10 cc. That is when you call it bulky ovary. So remember, it is more than 20 follicles. So basically, follicle number per ovary, FNPO, should be more than 20, and all the follicles should be non-dominant. None of them should be more than 10 mm. Okay, so please remember this point has been asked in the recent FMG exam. Going to next one. So we are going to do PYQs like section wise, topic wise. First, the basics one, investigations, anatomy one. Then we will go system wise, respiratory, CVS, GIT, right? Neuro and all of that. So I asked in INI-CET 24, what is true regarding CT scan? Which of the following is true regarding CT scan? It was more than 12 previously, but now it has been changed to more than 20. Right, it is the CT score of water is 0. This is what is true. Remember, in CT, you have the concept of HU value, and water is something which has HU value of 0. What has negative HU value? The two substances which have negative HU value, which are less dense than water. Remember, it is air and fat. These are the two substances which have negative HU value. Fat being minus 50 to minus 100, and air is minus 1000. Okay? Right. Going to next one, what MRI sequence is the one that you are seeing here? What is this? The CSF, the ventricle, the water. The water is white here. If the water is white, World War II, WW2, it's going to be T2 weighted MRI. This is not stir. This is T2 weighted MRI. Stir is something that we use in like musculoskeletal imaging. It's a fat suppressed sequence. Like you have flare in MRI brain, you have stir in a musculoskeletal imaging. This is T2 weighted MRI. And what MRI is this one here? This is a susceptibility weighted imaging where you see these veins, a lot of vessels in the brain which are seen, right? The deoxygenated blood appearing black there. It is SWI MRI, which helps in identifying hemorrhage. It is also a sequence which helps you differentiate hemorrhage from calcification. Okay, it helps you differentiate that as well. Okay, going to next one. What will be answer to this one? This is INI-CET 2025 question. So do not get scared just looking at the term difficography. Oh my God, what is this? I don't know that. But look at the options. Is it X-ray or is it MRI? Is this MRI? No. Look at the image very carefully. Can you appreciate this pelvic bone in the background, right? These bones in the background, how the bones appear on X-ray. That is how the bones are appearing. So this is the X-ray image. This is not a CT or this is not a MRI. This is X-ray difficography, which is more dynamic, right? Where you actually ask the patient to strain and to defecate. So that is X-ray difficography. Next one, best investigation for ureteric calculi, examiner's favorite, because these calculi, because these calculi are calcified calculi, so you go for CT. Remember NC-CT because calcification appears white on NC-CT, so you will go for CT. One of the recent exam question, like how will you approach any patient of acute abdomen? First, you do USD because it is fast, easily available, right? And then if needed, then you can follow it up with CT. So that was asked in the recent INI-CET exam. Okay. Next one. During the procedure shown below, what substance uptake basically by cancer cells are you looking at? This is your FMG exam question. So the image that you have is your white bone CT along with that color there. That's a PET CT. Okay, so remember in PET CT, what do you have in PET? It is glucose uptake by cancer cells. What effect are you looking at? It is Warburg effect, right? Warburg effect, glucose uptake. Absolutely right. Going to next one. Which contrast agent is safe to use in renal failure patients? Recent INI-CET exam question. Which contrast is safe in renal failure patients? Absolutely right. USD contrast. Why? Because the contrast that you use in USD is microbubbles, right? And they are excreted by the lung, so not by the kidney, so safe. Whether it is gadolinium or iodinated contrast media, they have renal excretion. So you will not use them in renal failure, but you can use USD contrast excreted by the lungs. Okay. Next one. What is the object here that you are seeing? Look at this appearance, the double ring appearance, right? Look at this double ring appearance and the step of effect that you have telling you there's a smaller circle and there's a bigger circle in that. So it's not a coin, it is button battery, which has a smaller circle and a bigger circle. So this is button battery. Double ring or halo sign is what is seen. Please remember, you need to remove it even if it is asymptomatic. Button battery, you cannot keep it there. Next, what is this one? See, this is your learning point for image-based questions. Don't break your heads on the image. You just have to take one option and see that whether what you know about that image is fitting into this. Is this emphysema? Emphysema has black hyperinflated lungs, but here you are seeing white. So that is out. Tension pneumothorax again will be black. You are seeing something white here. Right? So what is this white here? This is pleural effusion, the fluid appearing white here. It is fluid that is there which is white with the blunting of the angle and the curve that you are seeing here, which is called as Ellis curve. Right? You see this curve in pleural effusion. So this is pleural effusion with CP angle blunting and the curve. Next one, what will be answer to this one? What is the likely diagnosis? Yes? Okay, great. All of you say this is right middle lobe consolidation. Why? On what basis? On what basis do we say this? Correct. That's basis silhouette sign. Silhouette is the loss of border. So you can see the right heart border is not seen well here. It is obscured by this opacity. So whenever it is right heart border gone, it is right middle lobe pathology. Okay. And if it is left heart border gone, it is what pathology? Then it is lingula pathology. So this is right middle lobe, not the lower lobe, not the lower lobe, and this is not pleural effusion as well. This is right middle lobe pathology obscuring the right heart border. Okay. Next one, what will be answer to this one? Patient who has been treated for TB and now you see something on the X-ray. Right, this is one of the recent FMG exam question. Correct. This is aspergilloma because important history of a TB patient. So having cavity which is present and in that cavity the fungal ball comes and sits. So that is fungal ball aspergilloma. You have this cavity inside which is the fungal ball and you have the remaining air in the cavity which becomes like a crescent. So this is called as air crescent sign. Okay, monad sign like a crescent, like a moon, that is monad. Crescent, okay, air crescent sign, monad sign, aspergilloma. One step ahead, can someone tell me that how can you confirm that this air crescent sign is, or the pathology that you are seeing is aspergilloma only and nothing else? Because you can have air crescent sign in other pathologies like a tumor can also show this. How will you confirm? Absolutely right. It moves. If the patient changes the position, it moves. It is something which is mobile. So what do we do is we do a prone CT. In the prone position, it goes in the dependent part. Supine में वो पीछे की तरफ आएगा, prone में आगे की तरफ जाएगा. So it is mobile. Okay, this is something which is mobile and it proves it. Okay, correct. Next one. Where do you see popcorn calcification? Remember popcorn, hamara tomara popcorn. Let's share the popcorn, hamar tomar popcorn. So remember it's hamar tomar. That is pulmonary hematoma is what has popcorn calcification. In the breast, it is fibroadenoma. In the, if you see in the pelvis, X-ray pelvis में अगर popcorn calcification दिख रहा है, in a post-menopausal female, then what are you thinking of in that case? Post-menopausal female, popcorn calcification, what is the diagnosis there? Correct. It is going to be fibroid. And there is something in the brain. MRI brain pe what condition shows popcorn appearance in MRI brain? Yes. MRI brain में कौन सा condition में दिखता है popcorn appearance? No, not craniopharyngioma, not meningioma. It's something else. It is cavernoma or cavernous angioma. Okay, it is cavernoma. Okay, it is cavernoma, right? A vascular malformation, cavernoma, cavernous angioma, which shows popcorn appearance. Okay. Going to next one, 24-hour-old baby who's coming with respiratory distress and the X-ray is given. So this acute, immediately after birth, manifestation of respiratory distress with the bowel loops in the lung. This is going to be congenital diaphragmatic hernia, Bogdelic, more common on the left side. Okay, so this is CDH. Versus what is going to be the diagnosis here? Is this CDH? This is a 3-year-old child. This is not on day one itself. Okay, 3-year-old child with recurrent respiratory infections. And appreciate this air-filled appearance in the lung which is there, right? This is CPAM. Okay, congenital pulmonary airway malformation, previously called as CCAM, congenital cystic adenomatoid. Okay, so remember, the history is different, and that's why I said that the history is important in getting to the answer. Day one pe distress, it is CDH. 2 to 3-year-old child with recurrent infections, then you think of CPAM. Okay, next one. What will be the diagnosis in this case? Yes. Okay, cartilaginous. Why cartilaginous here? Because what do you see is situs inversus is what you are seeing in this question, right? What you are seeing here is the heart apex is towards the right side, and it's not just the heart apex, even the stomach bubble has come to the right. So this is not just dextrocardia, but this is situs inversus, right? So along with situs inversus, what will you think of? Cartilaginous syndrome. Okay, situs inversus bronchiectasis that is seen in sinusitis in cartilaginous. It's not just dextrocardia, but situs inversus. What is this one here? The heart apex going upwards. This is going to be tetralogy of Fallot. Okay, the box-shaped heart is tetralogy of Fallot. Epstein seen with lithium has box shape. In tetralogy of Fallot, sorry, this is boot shape heart. The apex going up. This is boot shape heart. Why do you get boot shape heart in TOF only? Because there is RVH present in TOF. It is not LVH but RVH. Okay, right ventricular hypertrophy is what is present in TOF. Okay, and in TGA you are going to have egg on string appearance, and in TAPVC you have the figure of 8 or snowman appearance. Like, look at the next question. What appearance are you seeing in this image here? So above the heart there is something, right? And then you have the heart here. This is figure of 8 or snowman appearance. Remember, snowman, snow falling from above, supra level. This is seen in what kind of TAPVC? Supracardiac TAPVC. Okay, type 1 or supracardiac TAPVC has this appearance. Next one. Identify the vascular structure which is marked here. So look at the vessel here. It is in front of the vertebra. This is trachea, esophagus. Esophagus ke piche se ja rahi hai. It is on the right side, right? Remember, this is going to be ARSA, aberrant right subclavian artery. So you have trachea, esophagus, behind that it goes. So it can compress on the esophagus from behind, and it causes dysphagia leucoria. What is it called as? Dysphagia leucoria. So that is ARSA, aberrant right subclavian artery. Correct. Next one. What is the structure on the barium swallow? Is it pyriform sinus, epiglottis, vallecula, or thyroid cartilage? So look at this barium swallow. Remember, the barium is going from the mouth itself. So you are seeing here tongue में white, फिर hypopharynx में यहाँ पे white दिखेगा. So this pointed lower part that you are seeing lined with this white barium, this is going to be pyriform sinus. And the upper rounded ones, these are going to be vallecula. Okay, those are the vallecula, and this is the pyriform sinus. Okay, so the lower pointed one, that is pyriform sinus. Vallecula upper wala hai, the more rounded one at the tongue base. Okay, what is this? Can you appreciate this black air beneath the diaphragm? So that is air under diaphragm. What is black on X-ray? Is air. So air under diaphragm, that is pneumoperitoneum. Common history that you will have in the question is history of peptic ulcer disease, right? That perforating leading to pneumoperitoneum. And remember, when there is perforation, you do not use barium there. Okay, you do not use barium in a case of perforation. Air under diaphragm is what you are seeing here. Okay, if I ask you the question that, the best X-ray for pneumoperitoneum is chest X-ray erect. But if the patient cannot stand erect, patient is in a very bad condition, then what X-ray will you take for that? In that case, what X-ray will you take? First is erect. If not erect, then what X-ray? Lateral decubitus. Which lateral decubitus? Right or left? Or it depends on the side of pneumoperitoneum, whether it's going to be right or left. Yes? Is it right? Is it left? Or is it depends on the side? Correct. It is left always. It is left always because when the left decubitus is there, the air goes towards the right side, and the air, if there is there in the lesser sac, that also will come out through the epiploic foramen. So you'll be able to see that air as well. So please remember, it is always left lateral decubitus with what beam of X-ray? Horizontal or vertical beam of X-ray? Is it horizontal or vertical beam of X-ray? Any decubitus X-ray is with horizontal beam of X-ray. Okay, that's with horizontal beam of X-ray. Always. Because decubitus mein, the beam has to come horizontal, parallel to the ground. Okay, right. Next one, what are you seeing here? Elderly patient with halitosis, dysphagia. Gives you the clue. We are thinking of Zenker's diverticulum, upper esophagus, posterior diverticulum going towards the vertebra. This is Zenker's diverticulum, right? What is the best investigation for Zenker's? It's not endoscopy क्योंकि perforation हो सकता है. It is barium swallow. Okay, it is barium swallow. ठीक है? Right? Which contrast can be used here? Were you asking in the case of pneumoperitoneum? So perforation mein we do not use barium because it's water insoluble. So you use water soluble contrast, that is iodinated contrast. Iohexol better than gastrographin. Okay. Next one. Right. The image itself tells you what is this? Dilated esophagus with this narrow LES, the bird beak appearance, achalasia cardia, giving this bird beak appearance. In achalasia, what is the gold standard investigation? It is manometry. What is a gold standard investigation? Is manometry. Right? Next one. What are you seeing here in this image? Non-bilious vomiting in a 6 weeks old child itself tells you that you are thinking of pyloric stenosis, hypertrophic one. And look at the image orientation. This is the liver here that you are seeing, right? And this is the part of the pylorus. This is the stomach part pylorus that you are seeing, which is elongated and thickened. So this is congenital hypertrophic pyloric stenosis. Remember, the investigation of choice is ultrasound because it has no radiation and it can measure the thickness as well to prove that it is hypertrophy. So when this is asked, it is the investigation of choice is USG. The cutoff for CHP is to call it a thick hypertrophic muscle, pyloric muscle. Thickness should be more than 4 mm and length should be more than 4 square, that is 16 mm. So 4 and 4 square, that is 4 and 16. Okay. Next one. What is this one here? Right. Look at the image. Okay, look at the image here. You are seeing 3 bubbles, right? 1, 2, and 3 bubbles. It is triple bubble sign jejunal. Duodenal atresia has double bubble. Jejunal will have triple bubble. So it is jejunal atresia. Next one, classical image. The image is a spotter image. The coffee bean sign. This is of sigmoid volvulus. So the what are you seeing here? Sigmoid volvulus will lead to large bowel obstruction because जब volvulus होगा तो proximal descending colon, transverse colon वो dilate होंगे. So it is going to lead to large bowel obstruction. Okay. Next one. What are you seeing here? It's a child with abdominal pain and there's a mass felt, sausage mass, pain. Red currant jelly stool, not mentioned in the question but will be there. It is intersusception. What is this sign called as? The barium, which is stopping like a claw here. What sign is this? This is claw sign, which is seen in intersusception. What is going to be the immediate management for this? It is going to be air enema or pneumatic reduction. Basically, air enema is what is done initially, not surgery directly. Okay. Next one. What are you seeing here? What is the diagnosis? Right. Look at this. This is the terminal ileum, which is narrow, and this is the cecum, which is so small, contracted, and it is pulled up. So you have this narrow terminal ileum, basically telling you that is stricture of the ileum, which is called as string sign. And this is the cecum, which is pulled up and contracted cecum. Okay, pulled up, contracted cecum because of the fibrosis. Everything in TB is because of fibrosis. So this is going to be ileocecal TB involving the ileum and the cecum. Okay, so ileocecal TB is what you have there. Next one, what is this MRCP image showing? You can see that there is dilatation of the CBD, which you are seeing there. So that is going to be choledochal cyst. There is no filling defect to say that there is any stone, right? So this is choledochal cyst, dilatation of the CBD. The intrahepatic also seems to be dilated. This is going to be choledochal cyst. This is not Carolese. Carolese is where you have in the liver, you have that central dot sign. Okay, intrahepatic hota hai. That is Carolese. Okay. Next one, identify the condition. Look at the imager. Where are you seeing the calcification? Look at the pattern of calcification. It is following the pancreas. Okay, going from the right to the left. So pancreatic calcification is what is this one. Where do you see pancreatic calcification? Remember C for C. Always think of chronic pancreatitis in that case. Okay, chronic pancreatitis, pancreatic calcification. Okay. Next one. What is the sign that you are seeing in the gallbladder? Look at this sign. The gallbladder wall is folded like this. It is showing this folding. So the gallbladder, instead of being a smooth wall, it has this infolding which is there. This is called as Phrygian cap, which is a normal variant, right? The gallbladder folding on itself. So that is Phrygian cap, which is normal variant. Okay, which is normal variant. Next one. What are you seeing here in this image? Are these polyps or are these diverticuli? Correct. So look at the image here. These are the outpouchings containing the barium, the outpouchings coming from the colon and containing the barium, right? So these are diverticuli. This is diverticulosis. What sign do you see in diverticulosis? The outpouching, multiple outpouchings, they give what sign? That is called as sawtooth appearance. Okay, that is sawtooth appearance. Clear with everyone? Yes? So sawtooth appearance. And remember, what is the investigation of choice for diverticulosis? You would do barium enema. But if it is diverticulitis, that is acute inflammation, then in that case, you do not use barium. So in that case, you will do CECT to look at how much is the spread of the inflammation, whether there is any rupture which has happened, right? So for that, it's going to be CECT. But when it is asymptomatic, then you will go for barium enema. Okay. All right. So someone is saying, as exam is nearing, I'm falling behind and missing off my targets. Kindly help. That's basically because of the anxiety creeping in. Kaise hoga, kya hoga, all those thoughts coming in and affecting your productivity and efficiency. Right. So please have a self-talk where, you explain it to yourself that the anxiety does more harm than any benefit. You cannot afford to waste time. So divide your days also in chota time blocks, giving yourself chota targets that helps you to increase your productivity. So tell yourself for the next 1 hour, this is my target. So it helps you to keep you a regular check on yourself, rather than at the end of the day realizing कि मैंने बहुत कुछ पढ़ा ही नहीं दिन में. You will have regular self checks, if you keep those chota time boxes. Right? Thank you so much, Dr. D. Vicky. Thank you so much. Will this need be difficult because of the reduction in questions? See, I cannot say that ki, it is going to be difficult and all, but let's try to understand this ki, however it is going to be, it is going to be for everyone. It's not that only for you that paper is going to be difficult, right? So it is going to affect everyone. So let's not focus on something which is beyond our control. Can we control, how the paper is going to be, what questions are going to be asked? Not at all. We can only control, how much efforts we are putting in now. So just take one day at a time, making sure that you are giving your best every single day. That's it. That is what you can do. Have the only target that post exam, I have to be satisfied that I gave my best. This is the best attempt that I could give. That should be your target and nothing else. है ना, बाकी जो होगा वो देखा जाएगा, बट एटलीस्ट जो हमारे हाथ में, हमको उसमें बेस्ट करना है. ओके. Yeah, so you shall soon get an update on, we will be having video-based questions, coming up with all the faculties, subject-wise hoga, and you will get an update soon on that, on a PrepLadder itself. Okay. String sign is seen in crons. Rose, absolutely, it is seen in crons as well. Remember, in radiology, the term string sign is used for where you have a smooth narrowing. So like in pyloric stenosis, the pylorus is narrow, right? So there also you get string sign. Crons also has terminal ileum narrowing, right? So that also has string sign. But the difference is TB involves the cecum also causing that contracted pulled up cecum. And that is why the answer to that question was TB and not crons. Okay. Cecal volvulus versus sigmoid volvulus aruba. Remember that sigmoid volvulus mein haustrations nahi hota hai. It's a smooth one. And coffee bean sign is seen in sigmoid only. While in cecal volvulus, it's a single loop. And it has more like an embryo-like appearance because it has these haustrations also present. So you have two loops here in sigmoid. You have single loop in cecum. You do not have any haustrations in sigmoid. You have haustrations present in cecal volvulus. Okay. Right? Okay, let's discuss this. Next one, what intracranial hemorrhage is this? Where you are seeing the sickle shape, crescent shape. Remember, sickle is SDH, crossing the sutures. That is why it has that crescent shape. It is going to be SDH. Okay. Next one, what are you seeing here? The blood in the CSF containing spaces. CSF is replaced by blood. That means it is subarachnoid space ka blood. So this is going to be subarachnoid hemorrhage. Okay, that's going to be subarachnoid hemorrhage. Thunderclap headache is going to be the history there. What is the first investigation that you will do? Non-contrast CT to look for the acute hemorrhage. Okay, non-contrast CT to look for acute hemorrhage. What is this image showing? Look at the skull bone. This is the skull bone. And suddenly this has gone inside. It is depressed. So this is a depressed skull fracture. Previous FMG exam question. Okay, it's a depressed skull fracture. Mount Fuji sign is seen in pneumocephalus. Remember, in the brain, cephalic cavity, this is where you have the air accumulating, giving that Mount Fuji sign is pneumocephalus. Okay, one of the INI-CET exam question. Next one, classical history, car accident hai, GCS score 7 hai, yeah, that is less, and non-contrast CT is normal. So the patient is in a bad condition. You think that CT will show a lot of things, but surprisingly CT turns out to be normal. This is the classical history in diffuse axonal injury. So what is going to be investigation of choice for that? It is going to be MRI. What sequence of MRI? SWI, susceptibility weighted imaging. What will it show? Punctate hemorrhages. Okay, it will show the small petechial punctate hemorrhages. Okay. Next one, what is the diagnosis here? Can you appreciate cystic lesions with a dot? Cystic lesions with a dot. So a cyst with dot appearance is a neurocyst, neurocysticercosis, showing the cyst with the scolex inside. So that is neurocysticercosis. In the last stage, in the end stage, the neurocysticercosis getting calcified, that gives the starry sky appearance. Later on, it will show starry sky appearance. Okay, brain abscess is generally like solitary. Okay, and it does not have this typical dot appearance that you are seeing in this case. Tuberculoma, remember important point on MR spectroscopy. That's what helps you differentiate TB from NCC. What peak do you have in tuberculoma is lipid peak. Okay, that is lipid peak is what you have on MR spectroscopy. Correct. Next one, what is this arrow pointing to? The tail-like extension of the lesion. So remember, this is dural tail sign. Remember, dura is meninges, so it is seen in meningioma. Though not specific for meningioma, any dural-based lesion can show it. But remember, meningioma has this dural tail sign. Okay, meningioma has this dural tail sign. What is the diagnosis here based on this image? Very good. This is Chiari type 1 malformation where what do you see? Everything looks normal except for this, foramen magnum ke yahan se you can see this cerebellar tonsil like thing going down. So there is tonsils, cerebellar tonsils getting down, peg like tonsils herniating down more than 5 mm ke beyond. It is Chiari type 1. Remember in Chiari type 1 you have a syrinx also present. In the spinal cord, you have this central canal dilated, right? CSF containing syrinx, which is there. And then what do you have in Chiari type 2 malformation? Remember, it has meningomyelocele and hydrocephalus. Important. Meningomyelocele, hydrocephalus is Chiari type 2. Okay? Clear with everyone? What is the classical history in vein of Galen malformation? Vein of Galen malformation is a AV fistula in the brain. If anywhere in the body there is AV fistula, hyperdynamic circulation, the heart is under pressure, remember it can lead to heart failure. So brain ka condition hai but heart fail ho raha hai because it's AV fistula. Brain ka condition hai, there's going to be hydrocephalus. So whenever you have history of a neonate with hydrocephalus heart failure, always think of vein of Galen malformation, and it would show something like this dilated vessel here draining into the straight sinus. Okay, that would be the classical image. Dandy-Walker malformation is something where you have a large posterior fossa cyst. There's a large cyst in the posterior fossa, cerebellar vermis is absent, right? Then you would see a large posterior fossa cyst in Dandy-Walker. Okay, clear with everyone? Yes. Next one. What is this image showing? Two vertebrae involved with the intervertebral disc. So whenever the intervertebral disc is involved, always think of TB spine. Okay, so it is going to be pot spine. Multiple myeloma does not involve the disc. It involves the vertebra. Okay, so that is pot spine, intervertebral disc involved. Coming to the urinary tract ke questions, PYQs, where do you have keyhole sign? The keyword is given there. Remember the bladder with the dilated posterior urethra. Why is that there? Bladder with dilated posterior urethra because there is a valve here. So it is seen in posterior urethral valve. Tell me what will be the investigation of choice for posterior urethral valve? Is it a ureterogram? Or is it IVP or is it MCU? What is the investigation of choice? Very good, Shivani, absolutely right. It is going to be MCU, not RGU. You want something to come from above, not from below. So it is MCU. In RGU, the contrast comes from below. So you do not want that because the valve will open. Okay, so you want MCU, that is going to be the investigation of choice. What are you seeing here? Look at the question saying that the lesion does not change in appearance or become bright after giving contrast. That means what does it tell you? That the lesion is non-enhancing. That means it is just water containing. There is no solid component there. So that's going to be a renal cyst. Renal tumor will enhance. ADPKD will have multiple cysts. This is only a solitary lesion. Okay, or hydatid cyst nahi hoga ye. This is going to be renal cyst. Okay. This is where you are seeing the multiple lesions in the kidney, gray fluid containing lesions in both the kidneys. That is where it is going to be polycystic kidney disease. Okay, that's going to be polycystic kidney disease. Correct. And what are you seeing in this image? Can you appreciate in the kidney here, there is a mass with something, the area showing this fat wala, dirty black appearance fat. When it is fat, it is lipoma. What lipoma? Angiomyolipoma. It has this fat which is present, the dirty black appearance. Angiomyolipoma. Where do you see bilateral AML common in what condition? Which syndrome has bilateral AMLs commonly? Yes? Right, it is tuberous sclerosis. Okay, TSC. Tuberous sclerosis has bilateral angiomyolipomas, which are common. Tuberous sclerosis. Absolutely right. VHL has a clear type of RCC, which is common. Okay. Next one. What is the answer to this question here? 6-year-old boy with recurrent UTI. Okay, whenever you have a child with recurrent UTI, start thinking of VUR, vesico-ureteric reflux, right? First of all, tell me what is the investigation of choice for VUR? Is it IVP, MCU, RGU? What is the investigation of choice? See, when you are saying that there's a vesico-ureteric reflux, that means from the bladder, it is going to the ureter. When will you see that reflux? When the patient is micturating. Only when the bladder is contracting, micturating, you will see the reflux happening. So you want the bladder to micturate, and therefore the investigation of choice is MCU, not IVP, not RGU. Please try to understand this concept. The bladder has to contract and micturate to see that reflux. Okay, and if the question is you want to see the scar in a patient of VUR, then what investigation will you do for that? The renal kidney may, because of the reflux, what scarring has occurred, for that you will do? Correct. For that you will do DMSA. Okay, for that you would do DMSA. Okay, absolutely right. That's a nuclear scan. Now look at this image. Is this image an IVP image? Is this IVP, MCU or RGU? If you say this is not a IVP, tell me the reason that why this is not IVP. This is not just X-ray. You are seeing this white is the contrast. This is contrast. This is contrast. Why this is not IVP? Tell me the reason for that. IVP is a KUB X-ray with contrast. So IVP also shows contrast. You see bladder in the IVP also. Please try to understand this concept that IVP is a contrast X-ray of KUB, kidney, ureter, bladder. You do not see urethra in IVP, right? Urethra you are seeing here. This is the urethra part. This is the bladder part. This is ureter and this is kidney wala part. Okay? So when you are seeing the urethra, definitely it is not a IVP. Okay, so that is why this is not IVP. This is MCU. But what is abnormal in this MCU? When I say MCU, it is micturating cystourethrogram. You fill the bladder with contrast, then the patient micturates and the contrast comes into the urethra. So you should see the bladder and you should see the urethra. If you are seeing the ureter, you are seeing the kidney, it is abnormal. So if you see a ureter and kidney In MCU, that is going to be abnormal. And what is it suggestive of? It is suggestive of reflux. So that is how MCU helps you to diagnose reflux. If you are seeing the contrast in the ureter, then you are seeing the contrast in kidney. It is a VUR. That is why the contrast has come there, right? So please try to understand this concept. This is VUR. Is this clear with everyone? Yes? Absolutely right. You should not see the ureter and kidney in MCU. Okay? Next one. Easy one. What is this one here? The two kidneys are fused in the midline U-shaped kidney, that is horseshoe kidney, associated with what syndrome? It is Turner syndrome. Okay, Turner syndrome में horseshoe kidney common होता है. Okay. Next one. What is this? What is going to be answer to this one? This is not a putty kidney. Please understand that it's given that it's a delayed IVP after 20 minutes wala image hai. So in a delayed IVP, what you are seeing here, this is the contrast. This is not the calcification. So this is the contrast here on the left side. You can see on the right side that there is contrast in the kidney and it has gone into the ureter, but you are not seeing the ureter on the left side, telling you that this is obstruction here. Okay, so there is pelvic-ureteric junction obstruction. So this is PUJ obstruction. So what will be the investigation of choice for PUJ? It is IVP with delayed images. Why delayed images? Because you have to be sure there is actually no excretion into the ureter, no matter at what time. Because some kidneys might have slow excretion. So you want to rule that out. Right? So remember, it is IVP with delayed images for PUJ obstruction. Okay, next one. What is this one now? Can you see this history of sterile pyuria, which is a very important history suggestive of TB? Right? Pyuria है लेकिन sterile है, कोई organism grow नहीं कर रहा है लेकिन pus cells है. So it's a very important clue for TB. And in TB, what do you have is putty kidney. Right? This is an X-ray image showing the calcification. Look at the pattern of calcification. Lobulated appearance. It's a putty kidney. Next one, coming to the OBGY wala part, what is the double bleb sign because of an early pregnancy? Look at the early pregnancy image. The outer one, what is the outer one? The big sac is the gestational sac. Inner one, you have one circle and another circle. So you have a yolk sac and amnion. Okay, so remember it is yolk sac and amnion which forms this double bleb, the two circles, yolk sac and amnion. Okay. Next one, what is this? Easy one. Important clue, hirsutism hai, obesity hai. These are basically, this is TVS image with the ovary and these are the follicles in the periphery. So these are the follicles in the periphery. This is going to be PCOS. Okay. Why not OHSS or theca lutein cyst? Because remember they have central follicles as well, not only peripheral. Okay, and they have the follicles which are big follicles occupying the entire ovary. Okay, it's not just peripheral but follicles throughout. What is this one here? Correct. Why is this adenomyosis? Because understand that in adenomyosis, what happens is the endometrial glands are going into the myometrium. So you will see this bright endometrium-like appearance in the myometrium. So this is what you are seeing here, the bright endometrial-like appearance in the myometrial area. So this is going to be adenomyosis. This is called as salt and pepper appearance. Remember, there is increase in the transitional zone thickness more than 12 mm. The transitional zone is thickened, right? And you have this salt and pepper appearance. Absolutely right. Banana sign on USD is seen in spina bifida. What is the banana sign? So with the crowding in the posterior fossa, what happens is the cerebellum gets curved like a banana. Okay? So it is seen in spina bifida. What other sign do you have? Remember, one is banana and other is lemon. Okay, so imagine two fruits, eating two fruits, lemon and banana. Okay, so lemon sign and banana sign. This image is showing this cerebellum which is curved like a banana because of the crowding happening. The spina bifida causes a pull on the brain structures leading to this folding of the cerebellum. So lemon sign and banana sign. What is this one? Easy. You can see this brain, open brain, which is anencephaly. The skull, the calvarium is absent. What sign do you get here? Frog eye sign. Okay, it is anencephaly. Earliest anomaly to be seen on ultrasound. It can be identified as early as 10 to 11 weeks. There's no point of giving folic acid now. Whatever defect was supposed to be occurring has occurred. The only treatment now is MTP, right? Nothing else. It's only MTP. Okay. Anencephaly is associated with oligohydramnios or polyhydramnios. What is there? Poly, right? Because the open brain, the CSF comes out into the amniotic fluid, adding to the amniotic fluid. So remember that it is polyhydramnios. Okay, polyhydramnios is what is present in anencephaly. Correct. What is this one? Black on ultrasound is, what is black on ultrasound? Air, fluid, calcification. What is black on ultrasound? USG पे black, X-ray CT में black is air, USG में black, is it air? Is it fluid? Is it calcification? Very good, Saida. Correct. It is fluid which is black on ultrasound. Okay. Fluid appears black on ultrasound. So this black that you are seeing are the cystic spaces, fluid containing spaces. So these are the multiple cystic spaces in the uterus, the snowstorm appearance of H mole. Okay, this is the snowstorm appearance of H mole. Okay? Correct. Next one, coming to nuclear medicine and radiotherapy. The principle of linear accelerator is used in the production of which of the following? Linear accelerator, that is LINAC. Very, very important. LINAC produces X-rays. It is X-rays that the LINAC produces, X-rays and electrons. Okay, there's an electron beam producing the X-rays. It is X-rays. Where do you use this LINAC? This is the most commonly used machine now for teletherapy, that is radiotherapy. पहले हम यूज करते थे कोबाल्ट मशीन, अभी जो हम कॉमनली यूज करते हैं वो है लाइनैक फॉर टेलीथेरेपी. ठीक है, इट इज एक्सरेज एंड इलेक्ट्रॉन्स. PSMA PET scan is used to diagnose which of the following? PSMA PET scan. Right, prostate specific membrane antigen. So remember, it is prostate cancer. Okay, it is for prostate cancer. PSMA is for prostate. What scan do you use for parathyroid? Very, very important. It is SISTA-MEB scan. Okay, that is MEB scan is for parathyroid. And versus MIBG is for not MEB but MIBG. What is MIBG for? MIBG is for pheochromocytoma. Okay, that is for pheochromocytoma. Okay, correct. Correct, Saida. Great. Next one, there's a patient who has a Honda sign, H sign. What is that suggestive of? Sacral insufficiency fracture classically has this H Honda sign. So it involves the sacrum bilaterally and the connecting bone as well. So remember, it is H sign, Honda sign is seen in sacral insufficiency fracture. Okay. Next one, for treatment of thyroid cancer, which iodine isotope is used for treatment of thyroid cancer? It's iodine 131. Remember iodine 131. It emits beta, gamma, alpha. What rays? Is it a pure beta emitter? No. It emits beta plus gamma. Out of that, the therapeutic effect is because of beta or gamma. Remember, it is the beta which is going to be therapeutic. Gamma has a very high penetration. It's not going to stay in the body itself. Beta will stay in the body and cause that therapeutic effect. So remember, it is beta. What is the half-life of iodine 131? Remember 1 plus 3 plus 1 plus 3, right? 1 plus 3, 4 plus 1 plus 3, 4. It is going to be 8 days, not hours. Remember, the therapeutic ones have a longer half-life in days. The diagnostic ones have a shorter half-life in hours. Okay? So remember, it is 8 days. What radioisotope do you use in PET scan? Remember, PET is FDG, so it is 18F. 18F is what is used in PET scan. Why do you use 18F only? Why not technetium 99, which is commonly used in scintigraphy? Why 18F? Because this is something which emits positron. PET is positron emission tomography. So you need a positron emitter. Versus technetium 99M, which is commonly used in scintigraphy, that emits gamma rays. It does not emit positron. So remember, that is why you use 18F, because it is a positron emitter. Okay? And can someone tell me what is the principle of PET scan? PET scan का principle का क्या नाम है? What is the principle of PET scan? Yes. What is the principle of PET scan? Anirudh, I'll come to your question. No. The name of the principle, right, that can be asked in the exam. Remember, the principle is something called as annihilation coincidence circuit. It is annihilation coincidence circuit, right? So it's like positron coming from the 18F combining with electron in the body. So there is annihilation, destruction, cancelling each other. And then it generates two photons which go and coincide on that detector. So annihilation coincidence circuit is the principle of PET scan. Okay, it is annihilation coincidence circuit. In which investigation do you use the principle of piezoelectricity? Yes, Saida. The first FDG PET is fluorodeoxyglucose. Fluoro is the radioisotope, deoxyglucose is the ligand. Okay, very good. Piezoelectric effect is used in USD. Okay, that's used in USD. Right? Going to next one. What is the most radiosensitive tissue in our body? What is the most radiosensitive tissue in our body? It is bone marrow. Why bone marrow? Because it is continuously dividing. So there is law of Bergoni which states that continuously actively dividing cells are radiosensitive. Nervous tissue is going to be the most resistant because it does not divide. If you have bone marrow also and gonads also in the option, then gonads are more sensitive. Okay? Clear with everyone? And also remember there's something called as recently asked question inverse square law. Can someone tell me what is inverse square law? What is inverse square law? Saida, F is for fluoro. Right, that's the relation between the radiation source and the distance from that radiation source. How the radiation intensity changes with distance. So the more the distance is there, of course, logically thinking, जितना distance बढ़ाओगे उतना radiation intensity कम होगा. कितना कम होगा? If you double the distance, the radiation intensity is going to become 1/4, inverse and square. If you triple the distance, the radiation intensity is going to be 1/9. If you make the distance 4x, it will be 1 by 16. So inverse square. Okay, that is inverse square law. Okay, and also remember recent FMG exam question, there's something called as Elara principle. Question asked was, what is the full form of this Elara principle? Anybody, what is the full form of Elara? Yes, Dr. Tushar. So this is used in brachytherapy. कि the tumor के बहुत पास में है radiation source, so it delivers more radiation as compared to teletherapy, which is away. Okay, Jayalakshmi says as low as reasonably accepted or something else. मैं कहाँ से हूँ, ये कहाँ से आ गया अचानक से? As correct, absolutely right. Panda hip hop. I don't know what names you have. So it is as low as reasonably achievable. So that's the concept of Elara principle, is as low as reasonably achievable radiation is what the patient should receive during any investigation. So as low as achievable but reasonably achievable. That means without affecting the image quality, because if the image quality is bad, again you'll have to take a x-ray, for example. So that's giving another radiation, and that is why you have this Elara principle, as low as reasonably achievable. Okay, that's as low as reasonably achievable. Another question which is there, and what is the full form of PACS? The PACS system, which is used in the digitized system, basically, for having the images being shared. You can see it on other systems as well. So what is the full form of PACS? Picture, correct. P stands for picture. What does ACS stands for? Is it picture acquisition? Is it picture archiving? Very good. Panda hip hop again, correct. It is picture archiving, not acquisition. It is picture archiving and not computerized system. It is communication system. It is picture archiving and communication system. Saving the pictures and communicating it. So picture archiving and communication system. Absolutely right. एंड देयर वाज वन क्वेरी, किसने पूछा था कि वो पोस्टीरियर अकाउस्टिक शैडोइंग दिखता है, ब्लैक दिखता है, वो फ्लूइड नहीं होता है, तो फिर वो क्यों ब्लैक दिखता है? रिमेंबर व्हेन यू आर लुकिंग एट अ गॉल स्टोन, द स्टोन, गो बैक एंड लुक एट द इमेज अगेन, द स्टोन itself appears white. It is the area behind the stone that appears black, and that is what is called as shadow. The stone is not appearing black, the stone is appearing white. It's the area behind that which is giving the shadow. Okay, so stone black nahi hai. Please try to understand that. It is fluid which is black on ultrasound. Okay, so now since we were talking about posterior acoustic shadowing, can somebody tell me where do you see posterior acoustic enhancement? Posterior acoustic enhancement is seen in very good. It is seen with fluid containing lesions, that is cyst, simple cyst containing simple clear fluid. Fluid basically shows enhancement. Okay, so cystic lesions show posterior acoustic enhancement, not stones. Remember, stones is posterior acoustic shadowing, the black area. Enhancement is the white area seen in cyst. Okay? Any other queries, guys? Fractures कौन से रिवाइज करवाऊं? स्टैग हॉर्न कैलकुलस कैसा दिखेगा एक्सरे पे? लाइक स्टैग हॉर्न, जैसे मल्टीपल हॉर्न्स वाला होता है, वाइट दिखेंगे क्योंकि वो कैल्सिफाइड है, एंड ऑन एक्सरे इटसेल्फ दे विल अपीयर वाइट विद द मल्टीपल हॉर्न्स लाइक अपीयरेंस. ठीक है? Any other queries? So that was a quick PYQ revision from my end, and I hope you've enjoyed it, like a quick fast revision. If you have any queries, please do let me know. पढ़ने के बाद ना सब कुछ इजी लगता है, जब तक नहीं पढ़ा होता है तब तक सब डिफिकल्ट लगता है, एंड दैट्स व्हाई द सेम पेपर आल्सो हैज डिफरेंट रिव्यूज एंड फीडबैक. सम विल से द पेपर वाज इजी, सम विल से द पेपर वाज डिफिकल्ट. See, whenever you get confused, in whatever things, like if syndromes, Think of it like, imagine like, a patient coming to you. So what I used to do is, make one of your known ones, your relatives, your friends, like एक disease का patient, and imagine them with all those conditions, and imagine कि ये patient में, like ये वाले मेरे friend relative में मैंने इसको ये disease दिया था, and this is what I had thought of. So that visualization, that imagination helps you to remember that. Okay, so when you're confused between NF1 and NF2, so किसी को NF1 दे दो, किसी को NF2 दे दो, और सोच लो कि उसमें क्या क्या दिखेगा और इसमें क्या क्या दिखेगा, and you will remember stuff better. Okay, so that's a smart way of remembering things. Yes. Dr. D. Vicky, that's how it is. You go to the restaurant, it seems like खाना कितना easily मिल जाता है. You cook by yourself, you know that it takes a lot of efforts and patience. Bone age estimation by X-ray, I think, that would have been covered in FMT. How to differentiate between PUJ obstruction and putty kidney based only on X-ray? Because putty kidney is a calcified kidney, so it will appear white on X-ray. PUJ obstruction it's a hydronephrotic kidney that does not have any calcification, so you will not see it on X-ray, right? You will see it on IVP, the dilated system that you would see. So X-ray पे वो white नहीं दिखेगा, putty kidney X-ray पे white दिखेगा. Okay, so if it is white on X-ray, it is putty, it is not PUJ obstruction. Right? All right. So I'll call it off for this session, guys, and probably I'll see you again, with more images and the possible videos that can be asked in the subject of radiology. There'll be a session coming up mostly on 10th. And thank you so much, everyone, for joining in. Last month tips. Most important that I would like to say is please maintain your calm. Baki sab to chhod do, but sort of be relaxed as much as you can. I know it's easier said than done, but that definitely helps you in improving your performance. And maximum revisions with a lot of MCQ practice, not just passive revision of notes and videos. That's not going to help you in the exam. You have to master the MCQ skills. So बहुत सारे MCQ solve करो और अभी retrospectively revise करो, rather than doing the same like चलो notes revise करते हैं. Don't do that. Okay, first is mastering the PYQs and PYTs. Please do the PYQs of FMG also. They are important for your NEET PG exam. Okay. Yes. Jai Jhulelal. Thank you so much, everyone, for joining in. See you again soon. Till then, goodbye. Take care. And keep studying, keep revising, keep mid-synapsing, and keep winning. Thank you.